This week I thought I'd try something new. I've been using Notebook LM to prepare a slideshow and summarize these articles, but I think that this week I will use my own notes and present a quick summary. Well, not quick, but it doesn't have the detail. For the detail, read the actual article. In doing this work, I often encounter the view, which is unsupported by data, that AI tools in combination with humans, with physicians, radiologists, pathologists, uh, generate better diagnostic conclusions than do either physicians on their own or AI on its own. This is not true, not valid, and this article explores that. AI is now demonstrably more accurate, faster, and significantly less expensive than human radiologists. It's not perfect, it has an error rate, but that rate is significantly lower than human error rates. And but we still do need humans to check over the results generated by AI. Although the problem from an implementation point of view is we need many fewer of them. So radiologists and pathologists, knowing that their competence is becoming rapidly obsolete, are doing what they can to slow down this implementation, although it is important to cancer and patient survival rates. The article quotes Dr. Curtis Langholtz of Stanford University. I remember the exact moment I realized AI would change everything. I was reviewing chest x-rays late one evening when our experimental AI system flagged a subtle nodule I had missed. Few cancers illustrate the stakes more starkly than lung cancer. Lung cancer remains the leading cause of death worldwide, in large part because it is rarely diagnosed early. Small nodules on CT scans may or may not be malignant. Radiologists must decide whether to dismiss, monitor, or biopsy them. They are often wrong. Their uncertainty can and does cost lives. At Google Health, Dr. Shavra Shetty, working with the National Cancer Institute and major medical centers, developed an AI system that analyzes not just individual CT scans, but the entire three-dimensional structure of lungs. The system also tracks changes over time, learning the subtle textures and growth patterns invisible to human eye. Dr. Michael Gould, a pulmonologist at Kaiser Permanente, who collaborated on the project, said the AI system could predict which small nodules would become cancerous with 94% accuracy. That's better than most experienced thoracic radiologists. Dr. Thomas Varghese oversaw development in one hospital network. We went from missing 20% of early stage cancers to missing less than 5%. That translates into hundreds of lives saved each year in our system alone. Across the country, AI is proving itself. Still, it is not being adopted as standard practice. The article then explores the use of AI tools, for instance, in Chicago, where it was successful identifying borderline lesions, the most difficult to diagnose, but still, those same hospitals decided not to use it, even though they proved it worked, it was cost efficient, extremely cost efficient, and much faster delivering results than human radiologists. In Europe, where the financial incentives are different, hospitals are adopting AI much more rapidly. The article then explores some exceptions, particularly in New York City, where three hospitals, NYU, New York University, Sloan Kettering, and Mount Sinai, uh, are adopting some of these latest FDA-approved radiology technologies. Um, in pediatric oncology, where many doctors see only a handful of rare cancers in their entire careers, AI could play a significant role. One innovation analyzes pediatric brain MRIs and can identify features experienced neuroradiologists can't see. For instance, how water molecules move through brain tissue. These are early indicators of tumor infiltration. These technologies reduce diagnostic uncertainty by 60% and enable surgeons to remove malignant tissue while preserving healthy brain function. Other AI tools explore deep into the human genome, where cancer hides its signals. Huge amounts of this data have been accumulated, but there is no way to access it or use it. In the early 2000s, Dr. Victor Volculescu, well, screwed that up, but Velculescu at Johns Hopkins recalled feeling overwhelmed after sequencing cancer genomes. We had all this genetic data, but it was like having a library in a foreign language. At the Broad Institute, Dr. Gad Getz built AI algorithms that could read this hidden language. His lab trained models on tens of thousands of patient genomes to distinguish driver mutations from harmless passengers. Collaborating with Dr. Shamil Sunyev at Brigham and Women's, they pushed prediction accuracy for harmful variants to above 90% and reduced false positives up to 20% in some settings. What took years of painstaking analysis now emerged in weeks, even days, giving oncologists insight into which mutations truly mattered. In some cases, for instance, identifying 14 different pathologies in chest x-rays, the breakthrough is not only in diagnostic accuracy, but in speed and consistency. It takes AI seconds to read a CT scan or MRI. It might take a radiologist 5 minutes or more. As Dr. Matthew Lundgren, a radiologist and AI researcher at Stanford, explained, a radiologist might read 100 x-rays in a day and perform at 95% accuracy when fresh, but that accuracy drops with fatigue. AI never gets tired, never has a bad day, and can process thousands of images with unwavering precision. Pathology is next after radiology. Pathologists spend hours analyzing tissue under microscopes, a process that is time-consuming and subjective. Pathology slides are ideal for digitization. Technology called Chief trained on 44 terabytes of pathology data across millions of slides, generated remarkable results. 96% accuracy across 19 cancer types, ability to predict survival outcomes directly from pathology images, identification of genetic mutations without costly genetic testing. In 2024, a randomized clinical trial published in the Journal of the American Medical Association, Network Open, compared physicians' diagnostic reasoning with and without access to a commercially available large language model. On its own, the LLM scored 92%, outperforming physicians. Yet physicians, when they were paired with LLM, did not improve significantly those to working unaided. In other words, with AI, they scored 83%. Without AI, physicians on their own scored 80%. And had they paid more attention to the LLM generated results, they could have achieved at least 92% success rate in the diagnostic reasoning. Researchers suggested that this may be because physicians were not trained on how to accurately interact with or effectively interact with AI. But there's more going on here. There's human bias, there's human aversion to technology that makes their special skills obsolete and the skills that they've spent years developing. And in order for these digitization tools to be implemented in a hospital, someone has to ask the hospital for the money, has to have it incorporated in the hospital's budget. And the people who would generally do that are the radiologists who would lose their jobs if the technology is adopted. And I mean, again, not all of them, but a substantial percentage, maybe 90% of the radiologists currently employed would be unnecessary if AI took the dominant role it should have based on its abilities. A study grounded in the Dunning-Kruger effect, conducted, I believe, at I can't think it right now of the university, but found that a major university in upstate New York um, found that individuals who overrate their own performance are less likely to rely on AI, hindering optimal collaboration. There are also legal and ethical concerns. When AI flags an abnormality that has been missed by a radiologist, it could increase perceived liability or AI penalty. So professionals may unconsciously emphasize AI's limitations in order to protect themselves. Among radiologists and pathologists, AI is widely considered to be a threat, and it is. Then there's a table in the article that um, reviews the different AI methods and the lead times that they're able to achieve versus conventional detection by humans. Um, Mirai, the technology developed at MIT to identify breast cancer risk, can predict uh, breast cancer up to 5 years ahead of humans. Insight MMG, also a mammography tool, 4 to 6 years. DBT-based AI model, 5 years. Uh, Forecast advantage over humans. Liquid biopsy, 8 to 30 months. Earlier relapse detection. So after a patient's been gone through chemo, found to be in remission, liquid biopsies can detect the recurrence 8 to 30 months ahead of humans or the current widely deployed conventional detection methods. DeepSeek can identify HPV-related cancers 8 to 10 years ahead of human or current technology. Blood protein biomarkers 7 years ahead for many cancers. Pan-seer liquid biopsies up to 4 years ahead. So in closing, I would just like to say, I hope nobody interprets this as my work here as a recommendation to try and work your way through a life-threatening diagnosis using AI rather than physicians and hospitals. That's the last thing I would recommend. They're all important tools. Use them all. Use AI to prepare questions for your oncologist before meetings. Use AI to determine which medical center to go to for treatment. Um, and but please don't try to do this without physicians and hospitals. It will lead to disaster. And thank you for listening tonight. Well, that's it for today's podcast. Thanks for joining us. Using the techniques described, AI for an initial search and in-depth interviews of leading physicians and medical scientists, Emerging Cures helps people dealing with life-threatening diseases find and take advantage of the latest groundbreaking developments in medical research. You can learn more at the Emerging Cures website, URL below in the show notes. There's also my direct email if you would like to contact me. To help us spread the word on this work, please like, subscribe, and follow this channel. It means a lot, and thank you.